Well, today I'm going to be talking about a concept known as left ventricular unloading. And we're going to be talking about this in the context of cardioprotection for acute myocardial infarction. So as Bill described, I actually spend a lot of my time between the cath lab, the basic science lab, and the large animal lab. And one of the driving motivations for this work comes from just taking care of patients. What you can see here is a patient of mine from October 2007 who presented to the hospital at this very early stage with a heart attack. He had a blocked left anterior descending artery. We opened the artery, as we're supposed to do, and we put in a small pump called a balloon pump to help the patient. At that time, the left ventricular ejection fraction was 20%. He survived his hospitalization, as many, many heart attack patients do these days. But then subsequently, I saw him in the clinic, and he was readmitted over the next few months with recurrent heart failure. And then about a couple of years later, he was readmitted and required another set of coronary interventions. And then further, over the years, I saw him in the clinic coming back with recurrent episodes of heart failure until about 10 years later, when he came back with extremely severe heart failure and was in cardiogenic shock. And at this point, we had to use a number of mechanical support pumps in order to stabilize his circulatory perfusion. And ultimately, he then received a heart transplant about 11 years after his heart attack. So I bring up this case illustration because this is what drives us in our laboratory, and to focus on myocardial recovery and trying to protect this heart from going on to the saga of 10 years of heart failure and ultimately developing cardiogenic shock. Now, as we know, myocardial infarction has had quite an evolution in terms of treatment. Since the 1960s, mortality for myocardial infarction had actually been increasing until the 1970s, when angioplasty came along, and actually since then, myocardial infarct mortality in the acute setting has reduced substantially. There's been terrific success. But what we've noticed actually is with this improvement in myocardial infarct mortality, there's actually been a subsequent increase in the amount of heart failure patients that are in society. And in fact, a vast majority of these heart failure patients represent ischemic heart disease. So one of the major areas for us is this question of whether or not we can protect the myocardium and reduce the burden of heart damage after a heart attack. Now, in order to understand the evolution of this field, it goes all the way back to the late 1960s and early 1970s. This was a paper written by Morocco and Brunwald, a famous paper in Circulation. And what these investigators did many, many decades ago was they tested the concept of actually reducing myocardial oxygen demand in a setting of a coronary occlusion by administering a beta blocker. And if they could reduce the workload of the heart, could they reduce the infarct size and subsequent myocardial damage? And that's what they showed in 1971, the field of demand reduction for heart attacks. But as innovation would have it, and as history would have it, balloon angioplasty came along within a couple of years of that Circulation paper. And soon enough, there were very rapid mechanisms of restoring oxygen supply by opening up a blocked artery. So as a result, supply became the focus and demand actually became less of the focus, because you could get a rapid, gratifying result of opening a blocked artery and thereby restoring oxygen and perfusion. What we've also learned now, decades later, after the advent of angioplasty, is that timing really matters. And in fact, every minute of delay from a blocked artery to reperfusion is associated with an increase in infarct size by about 30%. And in fact, that's for every 30-minute delay. And also, every 30-minute of delay actually increases your 1-year mortality by 7.5%. So the word delay is actually a 4-letter word in the setting of heart attacks. We don't want to delay at all, if at all possible. Now, in the modern era, with contemporary approaches to heart attacks, we're still seeing that despite rapid reperfusion, about 18% of total LV mass is infarcted. And that's irrespective of which territory has a blocked artery. We're also seeing that even in the contemporary era, every 5% increase in myocardial infarct size is associated with a 20% increase in 1-year mortality and heart failure hospitalization. So if we can reduce infarct size even by 5%, we have a potential benefit to patients. And this is why cardioprotection remains a holy grail that we are still trying to achieve in the space. So let's take a step back. We talked a little bit about supply demand, but if we look more physiologically at what are the components of supply and what are the components of demand. So supply, we know, is blood flow, coronary occlusion, collateral blood flow, multivessel disease, etc. But on the demand side, things like heart rate, wall stress, pressure inside the heart, and the workload of the heart are all variables that will increase myocardial oxygen consumption or demand. So if we were to try to reduce damage by reducing demand, we would have to unload the heart through one of these mechanisms. Now we know from the law of Laplace that if you start to have increased wall stress, this is going to drive adverse maladaptive remodeling. And so the idea is, can we reduce the components of the wall stress formula, which is pressure and volume inside of a cardiac chamber? And this is nicely illustrated by Doug Mann in 2012, when he discussed the concept of recovery and remission and remodeling. And what Doug basically described in this critical paper was that if you could reduce pressure and volume in the setting of acute or reversible damage, you might actually get a molecular response here that leads to cardioprotection, especially in the heart attack patient. If you have a heart failure patient, which is typical for many of our models, dilated myopathies, pressure overload, and weeks on end, then this is where you may be in the remission or the irreversible damage state. So the question is there a link between the physiology of pressure volume unloading and cardioprotection? Now, there are many pioneers in the concept of ventricular load, but more recently, there have been a lot of pioneers in the field of unloading. And so Dan Burkhoff, David Cass, my mentors, Kenji Sunagawa, have all been focusing on this concept of unloading through heart rate modulation, as well as through pressure and volume modulation. And in 1975, the earliest paper that was put out essentially showed this concept of the pressure volume area being directly coupled to myocardial oxygen consumption. And when we look more carefully at oxygen consumption, it's cross-bridge cycling, excitation, contraction, coupling, and then basal metabolism. And now, almost 40 years later, the same concepts still hold true. This is now a much prettier diagram in color, but essentially a substantial amount of the pressure volume area is driven by mechanical work. So what if there was a way to mechanically take away this work component and allow the heart to have less oxygen consumption when it has one hand tied behind its back with a blocked coronary artery? Now this, of course, is why we're here today, because over the past 15, 20 years, there's been a massive surge in innovation around mechanical heart pumps. These heart pumps, when I was training in fellowship, used to look like big, bulky devices that would be surgically implanted into your right or left ventricle. But now, over the years, what's happened is these devices have now miniaturized to the point that they can be inserted through a 3 to 4 millimeter incision in your leg and deployed within 5 to 10 minutes and start to unload the heart as quickly as possible. So the engineering has now led us to this question of the concept of mechanical unloading. And we've been studying these pumps for about 10, 15 years almost. And what we've learned actually is that if you are able to put a transvalvular pump, which means a pump that sits across the aortic valve, takes blood directly out of the left ventricle and puts it into the aorta, that the pressure volume loop responds in such a way that there's a significant reduction in pressure and volume. And in fact, if you look at this pressure volume loop, which may or may not play as cleanly as we like here, at the end of this pressure volume loop sequence, what you'll see is a triangular shape to what is otherwise a rectangular pressure volume loop. And when we see that triangular shape, what that means is that you've lost isovolumic contraction and relaxation, which are really the primary energy consuming components of the pressure volume loop. So achieving that triangular shape suggests that you have actually quite effectively unloaded the heart. Now, with this engineering in place, we started to shift our attention towards cardioprotection and cardioprotective signaling. And what we've known over the years is that many of the focused areas for reperfusion injury have been trying to essentially deliver a therapeutic as quickly as possible before reperfusion. But remember, delay is a bad word in acute MI management. And so you don't want to delay in order to let your drug have an effect, for example. And of course, the canonical pathways are the risk pathway and the safe pathway, leading to downstream effects on the mitochondria. So one of our first early investigations was to start to pick apart potential cardioprotective strategies and to introduce this concept of balancing supply-demand mismatch as an approach to cardioprotection, and then to look at all of these potential molecular pathways that may be implicated in the protective effect. So to achieve unloading, as we said, we want to reduce any of the variables in red that might start to cause load or increase consumption. So this work began in 2009, and our first attempt was to reduce LV work and essentially do this using a pump that would take blood out of the left atrium and put it into the femoral artery, thereby reducing cardiac preload substantially, which would reduce pressure and volume. Now, when we designed the study, our goal here actually was try to replicate what might be happening clinically and to make this clinically relevant as possible. So 120 minutes of left anterior descending artery occlusion, followed by reperfusion in adult male swine. Now, in the treatment arm, it technically takes a few minutes in order to actually get the pump to work in the clinical arena. So we imposed a 30-minute delay to account for that delay that would occur in the clinic. And so, in fact, these animals in the treatment arm had about 150 minutes of exposure to LAD occlusion compared to 120 minutes of occlusion. And what we found was that with this pump that drained blood out of the left atrium, put it into the femoral artery, there was a substantial reduction in stroke work, and that this was actually associated with about a 40% reduction in the myocardial infarct size. And you can see the TTC stain here with a nice reduction that was fairly consistent across the unloaded animals. Now, this introduced the idea that prioritizing myocardial unloading before reperfusion might actually maximize myocardial salvage. And it also introduced this idea of a 30-minute delay before reperfusion. Remember, delay being the bad word, but in fact, we found that despite the delay, you actually saw a significant benefit in terms of infarct reduction. Now, when we started to look at signaling, this was a very new concept, this idea of left atrial to femoral artery bypass and unloading. We first just looked at canonical signaling through the risk pathway and found that basic things like AKT and ERK actually were increased in the unloaded heart compared to the loaded heart. And so this began the idea of starting to take a deeper look at mechanism and how this might be translating to a cardioprotective effect. Now, around that time, we did design and attempt to do a trial of using the left atrial to femoral artery bypass pump to see if we could do that in patients to improve myocardial salvage. This trial had 0 enrollment, and in fact, the major problem with the trial was the engineering. It's very challenging to put a puncture into the left atrium, insert a garden hose into the left atrium while someone is having a heart attack, and then ask someone to stand around for 30 minutes before opening a blocked artery. Technically, very challenging to do. Now, device innovation opened a new door around the same time, and this is when this small transvalvular pump was developed that could go through that 4-millimeter incision in your leg, and it could be delivered over a wire into the ventricle. And as you can see on the pressure volume loops, we actually saw that there was a substantial reduction in pressure and volume with the unloading of this transvalvular pump as shown in this small pressure volume loop here. So the amount of myocardial oxygen consumption and that mechanical work was now being replaced by the pump as opposed to the native heart that had a blocked artery. And in this study, I wanted to make sure that we really pushed the experimental or treatment arm further. And so here we actually imposed 60 minutes of delay. And this meant that there was 150 minutes of ischemic burden in the treatment arm versus 90 minutes of ischemic burden in the control arm. Now, based on all the clinical data, we should be seeing a significant increase in the infarct size the longer you delay reperfusion. But in fact, what we found was that if we had primary unloading or unloading of the heart before reperfusion, even with a 60-minute delay, that there was again a 40% reduction in the infarct size. And in fact, the infarct size regression correlated directly, once again, with wall stress, that law of Laplace concept. Now, what we did learn in here in this study was that there was some more mechanistic insight because we found that myocardial levels of stromal-derived factor 1 alpha, which is also known to be a cardioprotective cytokine, actually were increased in the unloaded hearts compared to the non-unloaded hearts. So this started to suggest the concept that perhaps there's a biologic response in addition to the physiologic effect of balancing supply and demand mismatch. And in fact, maybe cardioprotective signaling is upregulated. And is this being done through SDF1 alpha? So we embarked again further onto the pathway, exploring different signaling mechanisms. We stuck with the canonical ones to start, and we saw that indeed the risk pathway through AKT, ERK, GSK3 beta were all upregulated in the presence of primary unloading, despite the 60-minute delay. And we also saw that there was an increase in BCL2 expression, suggesting a shift towards an anti-apoptotic environment compared to the reperfusion arm, which was pro-apoptotic. So from that second study, we then started to come up with the paradigm that actually unloading of the heart not only had a physiologic effect, but actually enhanced cardioprotective signaling, and that may be contributing to this reduction in infarct size. But many questions remained unanswered. One of the major questions that we were receiving, especially from the clinical community, was how could you possibly delay? And do you need to delay? Can we just actually put the pump in and open the artery as quickly as possible? So we embarked on a kinetic study in the preclinical model. And what we showed was that if you delayed for 15 minutes in group 2, 30 minutes, or if you open the artery and then put in the pump, would you actually still get the benefit of the infarct reduction? And all of this is designed to be more clinically palatable if we were to translate this concept into the procedure areas. But what we found in this study was that 30 minutes of unloading before reperfusion was necessary, and it was sufficient. So we didn't need to necessarily go beyond 30 minutes. And if we tried to shorten it by around 15 minutes, we could see that there was less consistent effect. And if you open the artery and unleash reperfusion injury and then unload, then actually you lost the beneficial effect. So what we learned from the kinetics was that you had to unload. And in fact, ideally, you could wait and allow the cardioprotective pathways to be activated and then see the effect on infarct size. Now, 30 minutes of delay is still not palatable to a lot of folks, so we still wanted to take a deeper dive into mechanism. So one of the things we did, and again, I like the idea of using omics-based platforms, especially because it takes the bias out of our hands. We deliver these samples, and in an unbiased, blinded fashion, we get an analysis back. And what we learned was that from the infarct zone, the transcriptomic profile actually in the reperfusion arm showed quite a bit of distinction compared to the sham uninjured heart. But actually the unloaded pattern started to look more like the sham or uninjured heart. And when we looked at the pathway analysis, many things started to point towards the mitochondria. And so when we looked more specifically at the mitochondria from the infarct zone, with primary reperfusion, you see the classic swelling and rupture and the blebs that are forming in the mitochondria. But within the infarct zone, actually the mitochondria here in the unloaded hearts looked quite intact and actually looked very similar to an uninjured myocardium. So this pushed us further, and we started to look again at that question of signaling. And when we looked more specifically at SDF1 alpha again, we confirmed our previous finding that in fact protein levels of SDF1 alpha were significantly increased in the infarct zone of the unloaded hearts compared to non-unloaded hearts. And in fact, this SDF signal was fairly profound. We wanted to understand why you're getting higher concentration of SDF1 protein. And what we found was that proteases that are known to degrade SDF1, such as MMP9, MMP2, DPP4, were all downregulated in the presence of unloading. And so this started to suggest that you may actually be seeing that the proteolytic environment is suggesting that SDF degradation is less likely to occur, and we may be concentrating SDF1 in the infarct zone. Now, one of the questions was how important is SDF1 alpha? So we have this physiologic mechanism, we have this mitochondrial effect, and so we then treated unloaded hearts with AMD 3100, or a neutralizing antibody against SDF1. And we found that if you neutralize SDF1 activity, this attenuates the cardioprotective effect of unloading and delayed reperfusion, suggesting that SDF1 may be playing an important role. The downstream signaling also was attenuated in the presence of AMD 3100, suggesting that, again, the risk pathway may be important in this cardioprotective effect of unloading. Now, we also looked again at the apoptotic pathways and found that indeed the 30 minutes of unloading replicated the prior study, which had 30 minutes of delay, but now 60 minutes of unloading. And we saw that again, BCL2, caspase-3, and Bax levels all shifted towards an anti-apoptotic phenotype. Now, one of the major questions again for translation is how durable is this effect? Up till now, we've shown you acute effects on infarct size with TTC staining. But what about 30 days later? Do you actually still see a durable benefit in terms of scar reduction, cardiac function? And if the mitochondria are truly preserved, does this mean that we've now started to set the stage for myocardial recovery? So we actually created a preclinical trial in the large animal lab where we randomly allocated pigs to either reperfusion alone or primary unloading for 30 minutes. And we tracked them for 28 days. And then at 28 days later, brought them back to the lab for further evaluation and looked at scar size. And what we found was using LGE scar enhancement by cardiac MRI, as well as just anatomic pathologic quantification of scar, that unloading had a durable effect on scar reduction 30 days after the heart attack. And there's a nice correlation between the LGE and the anatomic scar. In the paper, we also showed that actually functional recovery also occurred with the unloaded animals, an improvement in not only ejection fraction, but stroke work generation, DPDT, and other measures of load-independent contractility. Now, on the bottom panels in E, F, and G, we started to again continue to chase down this SDF1 pathway a bit further and found that there was a difference, that we saw that with primary unloading, there was a higher concentration of circulating as well as myocardial SDF1 alpha in the hearts and in the circulation, and that the plasma SDF1 alpha level correlated inversely with scar size. The more SDF1 around, the smaller the scar size. Now, when we looked at the non-infarct or remote regions 28 days later, we also wanted to see whether we were affecting fetal gene expression and other canonical pathways of maladaptive remodeling. And what we found was that, in fact, things such as BNP expression, a marker of congestion or heart failure, both at the myocardial level and in the circulation, were reduced 28 days later. We also found that circa, calcineurin, collagen as a measure of fibrotic remodeling, as well as beta MHC, were all attenuated in the remote regions after 28 days after infarct, again suggesting a pattern of potential myocardial recovery after a heart attack, as opposed to progressive myocardial damage despite the acute unloading. So in this paper, we started to shift our thinking a bit. We, again, just sort of re-emphasized and confirmed our SDF1 findings. We showed that their canonical pathways are active. We showed that the 28-day scar size was durable in terms of the effect. And importantly in this paper, we showed that 30 minutes is important for delay to reperfusion. Now, the reason why this paper was particularly important is because what we introduced is the concept that for the first time, you could actually put in a heart pump. And during those 30 minutes, what could you do? You could actually now potentially deliver drug therapy and actually enhance cardioprotective signaling or cardioprotective effects, because you wouldn't be rushing to deliver drug upstream of reperfusion. You actually would have time now. So this window in time opens an opportunity as we go forward in the exploration to consider drug device combinations to further reduce infarct size and enhance recovery. Now, based on that early data in that preclinical trial, you saw that with the left atrial pump, we couldn't get anyone to enroll in a trial. But we then embarked using this smaller pump and completed the first translational leap, which is a pilot trial in 50 patients with a heart attack. These are all patients coming in with left anterior descending artery occlusion, much like our preclinical model. We put in the pump, and the goal here was to test the safety, feasibility, whether or not doctors would actually comply with the idea of unloading and waiting 30 minutes, which again, for decades has really been ingrained in our genetics to not do that during a heart attack. So all 50 patients received the pump. They were then randomized into unloading versus immediate reperfusion versus unloading and delayed reperfusion. And what we found was, again, this new experience, and you can see here on the left, this is an angiogram of a patient coming in with a blocked left anterior descending artery. And for the first time, we actually waited 30 minutes after putting in a heart pump. You can see the heart pump here. And now we waited 30 minutes And then we opened up the artery and fixed the blockage. So this was actually a fairly new experience for us, but one of the things we learned was that clinically, patients were actually doing well. As soon as they were put on the heart pump, their heart rate started to improve, their blood pressure started to stabilize, and their left ventricular and diastolic pressure started to reduce, suggesting the unloading effect was actually having a clinical impact on the patients. And opening the artery takes about 5 minutes, and so all of these patients had their arteries repaired during that period. Now, one of the important aspects of translating bench work to clinical work is again showing feasibility and safety. And what we showed in this study was that actually all of the operators were allowed to bail out and open the artery as quickly as possible if they felt the patient was unstable. But we had 100% compliance with 30 minutes of delayed reperfusion, which starts to tell us that actually clinicians are beginning to see that patients are stabilizing and they're not sensing the urgency to open that blocked artery. Now, what we also saw in this study was that in the unload and immediate arm, with the patients, we saw that there was more infarct compared to the unload and delayed reperfusion arm in blue. And when we started to stratify patients based on the area at risk, so the way you can do this clinically is by looking at the EKG, and in the patients who had the largest area at risk, the benefit was maximized. And in fact, we saw that the unloaded hearts had more significant reduction in infarct size compared to the unloaded and immediate reperfusion. So this trial hit a few points for us. It hit safety, feasibility, compliance with the protocol, and it started to suggest an early signal of potential clinical benefit by suggesting that the 30-minute delay, just like we saw in the preclinical model, is important to get the cardioprotective effect. Now, when we look more closely at the data from the clinical trial, what we saw was an interesting observation that, in fact, the duration of LV unloading before reperfusion actually was inversely correlated with infarct size, suggesting a bit of a dose-response effect, that the more prolonged unloading exposure you had, that actually you were maybe getting more cardiac protection. So we took these clinical data and went back to the bench, and the question was, does LV unloading start to affect ischemia before reperfusion? And in fact, are we having an ischemic effect? Now, around the same time, the Ishikawa lab from New York was starting to show that with these unloading pumps, they were seeing enhanced coronary flow through the myocardium, even though the artery was blocked, or if the patient or if the animal had a scar from an infarct. We took some of these concepts and started to test this in our laboratory. And what we found was that with unloading on the right, there was an increase in microcirculatory coronary flow. And in fact, this started to shrink the area at risk. So if you were to open that blocked artery and 50% of the area at risk is infarcted no matter what you do, another potential mechanism is that by reducing the area at risk, you're already going to see a reduction in the infarct size. But the real question was, we saw the physiologic effect, but does LV unloading actually reduce myocardial ischemia? Is there something called functional reperfusion by unloading the heart, as opposed to just having to do epicardial reperfusion every time? And so to answer this question, we started to look at hypoxia-sensitive proteins. So we started to look at things like HIF-1 alpha. We looked at PhD proteins as well. These were obviously highlighted most recently by the Nobel Prize in 2019. And this area of biology is under active investigation in the laboratory. But the first question was, if you actually are reducing ischemia, we should be seeing a change in HIF-1 and PhD expression, suggesting that the pump is having an effect independent of reperfusion injury. And so we created a preclinical study where we uncoupled ischemic from reperfusion injury. In group A, we had 210 minutes of LAD occlusion. And we then had two groups, one with no pump and another one with unloading for the remaining 120 minutes after 90 minutes of occlusion. In group B, we replicated the ischemic time, but we added 120 minutes of reperfusion. So now we could look at the effect of unloading on ischemic injury versus reperfusion injury. And what we found here in panel B is that there was already a reduction in infarct size to the area at risk with just ischemic unloading before reperfusion. But indeed, we confirmed the canonical finding that once you reperfuse, the infarct size actually goes up substantially. And in fact, in both arms, we found that infarct size was increased by almost the same magnitude, but because we had had some protection during the ischemic phase, the reperfusion injury was reduced. And when we looked more specifically at HIF1 alpha and PHD2 and PHD3 levels, we could see that actually HIF1 was upregulated with ischemia alone, but in the presence of unloading, HIF1 was reduced and PHD2 and PHD3 levels were also reduced. So this started to suggest this concept of functional effects on ischemia independent of reperfusion injury. What we also started to do in this study was to test whether or not different types of unloading could have a similar effect. There's another pump that's very commonly used, and there are 4 active clinical trials in Europe that are trying to use this pump called VA ECMO. Now, VA ECMO, very briefly, takes blood from the venous system, oxygenates it, and then puts it back into the arterial system. So it reduces cardiac preload, and that's how it's able to get the effect of unloading. But what we found in this study was that actually the transvalvular pumps had a significant reduction in infarct size. But if you used the ECMO circuit, that actually the infarct size, despite reducing stroke work, had an increase. And we think that some of this effect may be related to the oxygenator, to the extracorporeal circuit, and that there are different effects of this type of pump. So the takeaway from this slide was that not all unloading approaches are equal. And in fact, the transvalvular unloading might be a more effective way to achieve the infarct reduction. Now, again, in this most recent study that's coming out this month in JACC, this paper essentially, again, we took an omics approach. We handed off the samples in blinded fashion to Metabolon, allowed them to run the samples and provide us with our data so we could do the analysis. And the metabolomics aspect of this has really changed my thinking about a heart attack. I used to think as a clinician that a heart attack is a blocked artery. You open the blockage and you can reduce the heart attack. But in fact, I'm beginning to learn that heart attacks are really a metabolic attack. And in fact, the shift in myocardial energetics during a heart attack is quite substantial. What we learned from this analysis was that in the presence of unloading, there's actually preservation of myocardial energy substrate utilization. And I won't go into the details because of time, but what we found was that pathways such as glycolysis, fatty acid oxidation, and the Krebs cycle were actually more intact in the presence of unloading compared to just reperfusion alone. And when we did the Ingenuity pathway analysis, we found that, again, everything was pointing towards metabolism and mitochondria. And in fact, this mitoprotection concept started to become more relevant for our work. So our next step was to look more carefully at mitochondrial structural integrity. And as we showed before, the EMs were replicated in this study, where we found once again that with unloading with the transvalvular pump, mitochondrial structural integrity was intact. Membrane potential was also intact. But we started to take a little bit of a deeper dive into the structure of mitochondrial ETC complexes and found that cardiolipin content was actually also preserved in the presence of unloading compared to reperfusion alone. And in fact, the cardiolipin biology here is quite fascinating. What we're seeing is that the ratio of monolysyl cardiolipin to total cardiolipin actually is increased in the presence of reperfusion. It's maintained low in the presence of unloading, but with ECMO, the MLCL to total CL ratio actually goes up even further, suggesting potentially more oxidative damage and a reduction in cardiolipin biosynthesis. Now, we then performed seahorse analysis and found that when we look at all the ETC complexes, that in fact, complex 1 was definitely shut down by ischemia reperfusion. In the transvalvular pump group in panel B, complex 1 was intact and normalized to non-infarct territories. But in the ECMO arm, there was disruption of multiple complexes, again suggesting something beyond the unloading effect, maybe being the reason why you saw an increase in infarct size in group C. Now, when we look more carefully at complex 1, we performed a few different maneuvers to confirm that complex 1 function was intact with transvalvular unloading. We then took this a few steps further, used a different non-seahorse-based assay to confirm complex 1 activity was preserved with unloading. And we also looked more specifically at AD shifts, the shift between active and deactivated complex 1 isoforms, which is a critical component for generating ROS and during reperfusion injury. And we found that actually there's less deactivated complex 1 with transvalvular unloading And this correlated with a reduction in oxidative stress shown through catalase activity and reduced glutathione levels. So our takeaway from this most recent analysis coming out this month is that actually percutaneous transvalvular unloading preserves myocardial energetics, mitochondrial structural and functional integrity. And this has an impact, of course, on the acute effect of infarct size, but we actually think this sets the stage for myocardial recovery 28 days later by having those intact mitochondria and the intact myocardial energetics. Now, there's a lot more science to be done here in terms of taking a deeper dive in terms of all the different mechanisms that are operative. But this is where we are currently. And what's happened since that pilot trial is we've now designed the largest STEMI trial in history, actually, that focuses on unloading. This will be an 800 patient trial comparing primary reperfusion versus unloading followed by 30 minutes of delayed reperfusion in patients coming in with anterior LAD infarct in patients in the clinic. Now, what we've learned also is that ultimately this trial will focus on heart failure and infarct size as the endpoint. So as we talked about 4 decades ago, the idea of having a heart attack was a devastating terminal condition from which you were likely to die. In the 90s and 2000s, you survive your heart attack, but you develop heart failure. And what we're now suggesting is that on the platform of unloading, going back to that 1971 Morocco-Brunwald paper, by targeting demand, we might be able to not only salvage myocardium, but reduce the burden of heart failure in these patients. So our concept now is that essentially there is no delay when you actually unload the heart. What we're saying is the first maneuver is to not open the artery, but actually is to rest the heart and then open the artery. And so this is the concept of LV unloading, taking my patient from 2007, avoiding that 11-year saga, and allowing this patient to achieve myocardial recovery, which is the vision for the group so far. Now, I will put a plug here for our group. It's called ACURE. This is the Acute Cardiac Unloading and Recovery Group. It's a bedside to bench and back again global team of physicians and scientists. We have meetings that occur every year. This year, the meeting was to be held in Dallas. We'll see whether or not we're able to pull that off. But if you go to the ACURE website, you can engage with all of the science there and also submit abstracts and participate in the meeting as well. So I'll stop here and just acknowledge the immense amount of support that I've received from all of the team members in our lab, collaborators, funding agencies, and our industry partners who've really driven the innovation around the pump development. And just say thanks to our team of teams who's made all this work possible. And now I'm open for any questions. Thanks very much.
Thanks very much, Navin. Fantastic work, very eloquently presented. I have a lot of questions myself. Perhaps I'll just lead off with one thing I was wondering. The Impella device that you're using, is it pulsatile in nature? Does it predominantly decrease preload or afterload, or some of both?
It's a great question. So these pumps are continuous flow pumps. Now, when they're put into a pulsatile environment, they start to interact with that environment. So the way the pump works is the flow through the pump is dictated in part by the pressure gradient across the aortic valve. So when you have systole, the pressure gradient of LV pressure and aortic pressure are matched. But when the aortic valve is closed during diastole, the pressure gradient separates. So in fact, the pump flow is highest, its peak flow is during systole when there's no gradient. And it has a nadir when there is a gradient. So even though they're continuous flow pumps, by being dependent on the transvalvular pump pressure gradient, they do develop an undulation of flow. And so it's not what I would call pulsatile, because that's a loaded term, but essentially they do interact. So the sicker the heart, the more mechanical work that the pump will take over compared to a less sick heart.
I was interested because you mentioned the other device which reduces preload, and that didn't seem to be effective. And some work that we've done here in Oslo, we believe that it's the afterload which is really the critical signal, at least when it comes to cardiomyocytes, in terms of both compensation and decompensation. So I actually wonder if that might fit with what you're seeing.
Yeah, it's a great question. We had the same thought. And in fact, I went back to read ANREP's physiology concepts and the idea of load and acute load especially, because that pump, the ECMO pump, takes blood from the venous system and it puts it into the arterial system, thereby pressurizing the arterial tree. So in fact, we were hoping in that study design that we would see a loss of function, gain of function using 2 different pumps. But because these were healthy swine with a right atrial pressure of 2 or 3, that actually these pumps by draining all the blood out of the venous system, even though they're pressurizing the arterial system, we didn't see that persistent increase in afterload because some pumps essentially lost all their preload.
Right.
But this question of preload versus afterload dependence still remains open. And I think that the question of ECMO and infarct size expansion, I think may be related to the oxygenator and the oxidative stress that's imposed by that design.
Mm-hmm. Very good. I should go over to the Q&A. I'll just remind all of our viewers that they can post their questions here in the question and answer box. The first one is from anonymous attendee who says, amazing work. Thank you. That's a good start. Next one says, why is TVP better than ECMO as both of them unload the heart? Sort of address that.
Yeah, so I think that's what we were just talking about, is the idea that both reduced stroke work through 2 very different mechanisms. But one thing I'll point out for the group is that, remember, the first paper we published was using left atrial to femoral artery bypass. So in fact, everything is the same there. The oxygenator, the tubing, the pump takes blood from the left atrium, which is already oxygenated, and puts it back into the arterial tree. Now, in that case, we didn't need to put an oxygenator into the circuit. So our next area of exploration, and in that group, we saw a reduction in infarct size. So now by taking right atrial to femoral artery with an oxygenator, it starts to isolate down to potentially not only the hemodynamic effects, but this question of oxidative stress and isolating down to the oxygenator. So I think that's one major difference.
Very good. We have a question from Daniel Johnson, which I believe is Daniel Johnson in Stockholm. Really enjoyed your presentation. Thank you. In the transvalvular unloading experiments, do you also look at the location of the mitochondria? Were there more myofibrillar or subsarcolemmal? Was this altered?
It's a great question. And so we have started to look at that, and we don't have an answer for you yet. I can assure you that through this door to my left, there are many, many teams that are working on this now. What we're also doing, and not only in addition to looking at location, is we're also beginning to look at mitochondrial remodeling. And in fact, this question of what happens to mitochondrial biogenesis, mitophagy, changes in mitochondrial turnover, I think are critically important if the ultimate holy grail for us is myocardial recovery. So we've started to look at those survival models, and we've started to take a deeper dive into the mitochondria, not only in the infarct zone, but the peri-infarct and the remote zone. So hopefully we'll have answers for you within the next year.
Very good. Daniel has a follow-up question here. He says, following on from Bill's question, regarding the Impella, would you expect to see similar results with an IABP? Have you done any experiments with the IABP?
It's another great question. So the IABP is a device that creates a reduction in afterload, and it essentially is a partial reduction in ventricular load. And so because the IABP is structurally different, we think that it doesn't achieve the same degree of unloading as ECMO would in this case, or the transvalvular pumps. And so that's one, is just sort of the magnitude of unloading. But the second thing also is that with the IABP, there's also a very different effect on coronary physiology. We have not actually studied this in the large animal lab, but this was a trial that actually was completed in a few hundred patients looking at IABP activation before reperfusion. And in fact, they found that there was an increase in infarct size, or a trend towards an increase in infarct size with the IABP arm. And so we haven't pursued that arm because its effect on the pressure volume loop is not as significant as the transvalvular or the other extracorporeal pumps.
Very good. The next question. Braunwald and Morocco made some big mistakes, from an anonymous attendee, probably wise. They stated that just because a myocyte lies within a severely ischemic territory does not mean it is condemned to die. Well, yes, it does. You can delay injury, but you cannot prevent it. In your pig experiments, have you looked at infarct sparing 48 hours or more after intervention, or only after limited duration of reperfusion, 40 minutes?
That's a great question. So I think that I would say that we have all made a lot of mistakes, and I'm only showing you the clean stuff. So basically, what we've learned through trial and error over the years is that indeed this is true. And in fact, the kinetics of the infarct salvage is something we spent a lot of time on. And so we showed you a little bit about the 15, the 30, the 60 minutes. Now you've seen, in fact, 210 minutes with 120 minutes of unloading. We do actually believe that there is a dose response with the duration of unloading. And we've seen that in the clinical data as well, as that's beginning to become clear. But one of the questions that you bring up is this question of, is the myocyte condemned to die? And I think the real question for us is, are we taking this more global approach to the myocyte by targeting physiology at the coronary level, microcirculatory flow, targeting myocardial mechanics and energetics, and then targeting the molecular biology, all focused on trying to preserve the myocyte before any damage can occur. So I think this question about during the ischemic phase, what happens, is really important. And we are also adding that to our list of things to do. And that's one of the projects that we're quite focused on.
Sorry, Navin, Bill, do I have your permission just to ask a quick question?
Please.
Thank you. So, this may be a naive question, but I think you showed some of the data indicating that the microcirculation is sort of sustained better when you unload. So, in relation to this question by the anonymous attendee, is it then true to say that these myocytes are exposed to ischemic environments in the first place? So actually, yep. Maybe this is still a correct statement by the anonymous attendee, but maybe you're actually not seeing an ischemic situation because of the unloading and improved microcirculatory flow.
That's correct. And I think that's why the physiologic papers that were coming out suggesting this concept of functional reperfusion, blocked epicardial artery, but better myocardial flow, that actually goes back to the 1980s. So in fact, Richard Smalling was one of the first to demonstrate that there's an increase in microcirculatory flow with unloading. The physiologic basis for this also goes back to work by Dirk Brutstert and some of the early physiologists looking at coupling between myocardial wall stress, the NREP concept that we just talked about with afterload, and its impact on microcirculatory flow. So the point is that, I guess if we take a step back, 2 points. One is that if you unload the heart, the only time our hearts are actually unloaded in life is when we're a fetus. And in fact, we have a second heart pumping for us. And at that point, you're in a milieu that's very, very reparative. There's a lot of opportunity for repair. And so we think that by unloading, we're recapitulating some of the basic fundamental biology and physiology. But the HIF1 experiments that we showed today are the first signal that actually, from a biologic perspective, we may not be seeing as much ischemic burden, even though the epicardial vessel is occluded. And I think that's to your point, and also to this point, that in fact, we are an anti-ischemic approach as well as a anti-reperfusion pathway that's involved.
So have you considered maybe looking at sort of maybe intravital microscopy to look at microcirculation to see if you actually still have a sustained flow in those regions? That strikes me as something that could be done to actually maybe answer that question.
There has been some work with unloading. It's been done in peripheral organs, so organs outside of the heart, where they've looked at microcirculatory flow through the cheek or through the intestines, where you can see the flow, and there is indeed enhanced flow. But I think for the myocardium, it still remains open. But microsphere studies from several different labs around the world have confirmed this finding. What we're adding is this component of the biology, and that's why HIF1 and the PhDs are really a nice hypoxia-sensitive group of proteins that we can start to take a deeper dive into.
Great, thank you.
Very good. A good question here from Christopher Solis. He says, very nice work. Does SDF1 alpha pathway upregulation represent a therapeutic opportunity, or is unloading still necessary?
It's a great question. So as you can see from the work we presented, we certainly wanted to chase down the SDF1 pathway a little bit further. The AMD 3100 experiment suggested that it's really important to have SDF1 there. We found that actually, we did do a series of studies in that paper, which I didn't show you today, where we actually gave recombinant SDF1 in an effort to try to drive the cardioprotective signaling. And we did that with and without unloading. And what we found actually was that the unloading itself was reducing the infarct better than either arm, STF1 alone or STF1 with unloading. So the effect of STF1 seemed to be redundant on top of the unloading and didn't seem to have a synergistic effect. The second question about unloading still necessary, this brings up that question though about whether or not during that 30 minutes of unloading, if the STEMI DTU pivotal trial is successful, it now suggests that cyclosporin, Vendavia, all of the drugs that have been attempted in this arena of cardioprotective signaling, maybe the issue was that you couldn't get the drug to the area at risk in time for there to be a cardioprotective effect. But now if you had 30 minutes and you're standing there with a catheter in the coronary, you might actually be able to do that. And so that's one of our hopes going forward, is to explore the synergistic effect with drugs.
We have a question from Dipalyan Chadhuri. He says, I may have missed this, but are you measuring LV-EDP in the different unloading protocols, Impella versus VA ECMO, in the animal experiments? Does that correlate with outcome and gene expression in the animals?
It's a great question. And so LV-EDP, we do measure it. It's certainly in all of the papers, so you can see the data there. There is quite an effect on both biventricular filling pressures, right atrial pressure, as well as LV-EDP. It is reduced. We haven't done necessarily a regression specifically around LV-EDP. What we've been looking at most focused is around pressure volume area, because this encompasses the entire cardiac cycle. But I suspect that, and we do know from clinical work where LV-EDP can be measured, that does correlate with infarct size. But whether it correlates with gene expression, we haven't looked at that specifically.
Mm-hmm. We have another question here about pharmacotherapy from Heinrich Tegtmeyer. He says, very bold and very compelling. Could you comment once more on pharmacological unloading beta blockade, which could be initiated in the field, i.e. shortly after the onset of chest pain, MI?
Yes, another really important question, because heart rate is a critical component of load. And in fact, there are many studies, preclinical and clinical, suggesting that beta blockade given pre-reperfusion might actually reduce infarct size. What I think is that if you can unload, you'll reduce the infarct size. How you unload can be done through several different ways. I think the idea of combination beta blockade with a mechanical unloading device makes a lot of intuitive sense. Beta blocker alone, I think, might be a little bit challenging because you run the risk of hypotension or really profound bradycardia in order to get to the doses that you might need. But if you had a heart pump in place, heart rate can go as low as it needs to because you'll have a pump supporting your systemic circulation. So I do think that is a field that should be pursued in combination and in isolation as well.
Very good. We have a question from Argentina here, Luis Ganolo, who spoke earlier this week on a webinar. He said, very nice presentation. There is a strategy called remote post-conditioning. I was wondering about this myself, actually. Is post-conditioning still hip? I never know what's hip. Do you know if it also changes the levels of cardiolipin?
It's a great question. I don't know about cardiolipin with remote post-conditioning specifically. SDF1 has been quite well established in the remote ischemic conditioning models, and I think RIC holds a lot of promise. The mechanism still remains, open in terms of what exactly are the cytokines being released. I'm confident that I think that there is a biologic interface between remote regions in the myocardium, going all the way back to the original studies for remote ischemic conditioning. But I think the challenge with the term post-conditioning is one that I still debate about internally, because the challenge is that if you reperfuse, you've sort of let the cat out of the bag. And I think at that point, you're starting to do bailout maneuvers to have reparative mechanisms. But if you can preempt and prevent the injury, that's where I would hope to see more effects with remote conditioning.
Very good. Nice question here from Laura Sommerfeld. She says, thank you very much for the eye-opening talk. Maybe very basic, but thinking of the myocardial load, would you recommend to have the patient lying down or sitting during AMI?
It's a great question. I love this question. And I think that you're hitting on some really cool concepts, because sitting up is so different from lying down. especially as it relates to cardiopulmonary mechanics. So if you're breathing heavily, and we've learned this unfortunately through the COVID-19 pandemic, if you're lying down, and in fact, if you're prone more specifically, it's very challenging cardiopulmonary mechanics. But if you're sitting up, things are actually very different. And there is an effect of unloading just by sitting up. Now, for these patients who come in, they're having a heart attack. And in fact, the magnitude of load that they're experiencing by having a high LVEDP or wedge pressure because of the heart attack may not be sufficient to have them sitting up, and that probably alone won't take care of it. But I do think this hits at the fundamental concept of unloading and trying different maneuvers to do that. But I do think that as the technologies are advancing, we actually do the majority of our procedures through the wrist. And in the future, there are likely to be pump technologies that can be inserted through your wrist. And so within the next 10 years, don't be surprised if you see someone sitting up after a heart attack with a heart pump through their arm. And that might open that possibility. It's a great question.
I'm very proud, by the way. Laura is one of the PhD, second-year PhD students from Birmingham. Well done,
Laura. We have a slightly different question here. How and when will the ACURE meeting happen this year? How do I join?
It's a great question. There's a website. If you go to acure.org, you'll be able to pull it up. We are still planning to do this. We usually couple it with either AHA or ESC. This year it was to be coupled with AHA in Dallas. But if we are unable to do it in person, we will have a virtual meet. And that means abstracts, as well as faculty speakers. And I also want to plug the fact that there are fellowship grants available through ACURE focused on cardiac unloading and myocardial recovery, all aspects. So all these questions, all the people who are asking questions, please do engage. I'd love to find a way to fund you to answer some of these questions.
Very good. That just reminded me, I should make a little plug myself, actually, that I'm hiring 2 postdocs on this topic, mechanosensation transduction. If you're interested, I've just put the link in the chat. Or you can contact me by email. On to the next question. Oh, a follow-up from Henrik Tegtmeyer. He says, P.S. I love you. Oh, no, sorry, I misread that. P.S. I love your metabolic discovery strategy. Much more is to be learned about the dynamics of mitochondrial phospholipid and protein turnover, but you are taking a step in the right direction, and I look forward to your next discoveries.
I appreciate the feedback, and I will send my next paper and list you as a potential reviewer. Thank you. A lot of work to be done. Thanks.
And our last question, at least as of now, is from Khaja Abdul, who says, during MI, is it possible that cardioprotective signaling would get activated in an effort to protect the heart from injury? And is it possible that more than 2 signaling pathways get activated during 30 minutes unloading before reperfusion?
Yeah, absolutely. I think the answer to those 2 is yes. There's many pleiotropic pathways that are involved here. We started with the canonical risk and safe pathways, but we're discovering more pathways are involved here. And as I said earlier, all of the pathways are pointing towards the mitochondria as the end point. And so, other pathways such as AMP kinase, PGC1 alpha, a lot of these have really profound implications for unloading in cardioprotective science. So the answer is yes.
Very good. That takes us to the end of the question and answer. Davor, do you have anything further?
Well, I'd just like to thank you personally for a wonderful webinar. I mean, I have learned so much during this webinar, and you've given us fascinating insights into cardiac physiology and pathophysiology. I mean, I know I've actually received several texts saying this is amazing from friends that are watching this. So thank you. And I will be looking out for your work coming up. And Bill, thank you again for sharing, for your insight, and for your comedic timing. It's perfect.
It was a great talk. I really enjoyed it.
Thanks so much to you both. I really appreciate the opportunity, and now a member of IASHR, so I'm looking forward to engaging with you more. And thanks again for the opportunity. And Bill, thanks for sharing the session. Thanks so much for the opportunity.
Excellent. Thank you, everyone.
Bye-bye.
See you tomorrow.
Bye.